we are going to look at the anatomy of the abdominal walls as well as anatomy of the abdominal regions. This is the outline of what you're going to study. We are going to look at the anatomy of the anterior abdominal wall. We look at the structures which form the layers of the anterior abdominal wall. There's something called the Inguinal Canal. We are going to look at where it's found, what does it contain, and what its clinical importance. Then we look at the regions of the abdominal cavity. And for each region, we are going to name the abdominal organs which are housed in those regions. And finally, we will talk about the thoracic diaphragm. On this one, we are going to talk about its structure, and we're going to talk about the structures that go through it. So let's start with the first agenda, which is talk about the layers of the anterior abdominal wall. So the anterior abdominal wall has different regions. At this point here, we call that the anterolateral anterior abdominal wall. At this point here, we call that the paramedian anterior abdominal wall. And at this point here, we call that one the midline anterior abdominal wall. So there is what is midline, which means in the middle of the anterior abdominal wall. Then there's what is paramedian, which means parallel to the midline on either side. So maybe this is midline, then on either side, that is paramedian. Then if you go extreme lateral, we talk of anterolateral anterior abdominal wall. The structures that form the three regions of the anterior abdominal wall are relatively different. And that's why we try to divide it into those three parts. So we'll be looking at the structures that form the anterior abdominal wall for each of those three zones. It is much easier to talk about the anterolateral anterior abdominal wall than now figure out what is different in the paramedian and the midline anterior abdominal wall. So for that reason, we are going to start with the structures that form the anterolateral anterior abdominal wall. The best way to think about this is to imagine that you're inserting a needle into someone's abdominal cavity. Perhaps the intention is to withdraw some fluid within the peritoneal cavity. We call such fluid ascites. So you're inserting a needle to withdraw ascites from a patient's abdomen and inserting the needle through this end, the anterolateral side. So what we're asking ourselves is, what structures will this needle go through until we reach the peritoneal cavity? What structures will this needle go through until we reach the peritoneal cavity? To think through that question, let's understand it this way. So if you are to go through here, we will call that midline anterior abdominal wall. If the needle was to go through here, we'll call that paramedian anterior abdominal wall. But now the needle is going through here, and that's the anterolateral anterior abdominal wall. So we want to see what are the structures that the needle go through along this path here, the anterolateral anterior abdominal wall. At a higher magnified level, this is what we are seeing. So this is the midline anterior abdominal wall. Then around here and there are paramedian anterior abdominal wall, but around here and there are the anterolateral anterior abdominal wall. So let's start. The first thing that the needle will go through, if you're going through the anterolateral anterior abdominal wall, the first thing that the needle will go through is definitely skin. Skin therefore forms the first layer of the anterolateral anterior abdominal wall. The second structure that the needle will go through is that layer of fat. The layer of fat of the anterior abdominal wall is part of what we call the superficial fascia of the anterior abdominal wall. The superficial fascia of the anterior abdominal wall is considered to have two parts. There is a fatty layer and a membranous layer. So usually we first encounter the fatty layer before we encounter the membranous layer. The fatty layer of superficial fascia of the anterior abdominal wall is known as campus fascia. So after skin, the needle will go through campus fascia, which is the fatty layer of the superficial fascia of the anterior abdominal wall. The amount of campus fascia varies depending on individuals. In some people who are very lean, it's hardly any, although it's there, yes. And in those who are slightly obese, then it's almost like a deep sea. It could be very thick. Beyond the campus fascia, we go to the membranous layer of the superficial fascia of the anterior abdominal wall. And the name given to the membranous layer of the superficial fascia of the anterior abdominal wall is scarpus fascia. So scarpus fascia is the membranous layer of superficial fascia of the anterior abdominal wall, while campus fascia is the fatty layer of the superficial fascia of anterior abdominal wall. So this scarpus fascia is just a thin membrane, a bit hard to even to discern actually. Beyond the scarpus fascia, we now encounter the layer of muscles. So after this fascia, we encounter muscles. The musculature of the anterolateral anterior abdominal wall exists in three planes or layers. The outermost layer of muscle is the external oblique abdominis. This muscle arises from the lower parts of the body of the abdomen, which means from the iliac crest backwards. And then it spans obliquely upwards, going towards the ribs, towards the midline. So it runs obliquely. And that's why it's given the name external oblique. After that, we have what we call the internal oblique. This one arises from the upper parts of the trunk, then spans obliquely downwards. Internal oblique abdominis. Then lastly, we have the transversal subdominis. This one arises from the posterior abdominal wall and runs horizontally. That's why it's given the name transversal subdominis. So the external oblique will be the first layer of muscle, followed by the internal oblique, and lastly, the transversal subdominis muscle. After those layers of muscles, the next layer that we encounter, or the needle will encounter, is a layer of fascia, which we call the Fascia Transversalis. Beyond that, then we encounter the peritoneum. Now, if you remember the story of the pleura had two layers, the parietal layer and the visceral layer. Pericardium also has the visceral pericardium and the palatal pericardium. Even peritoneum has the palatal peritoneum and the visceral peritoneum. And if you remember from those first two examples of pleural and pericardium, the space between the visceral and the palatal layers of those membranes was a cavity that is occupied by fluid. In the abdomen, this is where that cavity is what we call the peritoneal cavity, and that is where the fluid will most likely be accumulating in. So if I'm inserting a needle to withdraw fluid, definitely the needle will go through the palatal layer of the peritoneum, but will not go through the visceral layer of the peritoneum, because the space between the two is where the fluid is. So the palatal peritoneum forms the wall, but the visceral peritoneum does not form the abdominal wall. These are the layers of the anterolateral anterior abdominal wall in order. Let me just say something about space between layer 7 and layer 8. That region there between layer 7 and layer 8 may also be occupied by fat, depending on, again, the body habitus of the individual. So in some people, you may have a very thick layer of fat there. In some people, you may not find much fat there. The fat that is found between those two layers is what we call the extraperitoneal fat, extraperitoneal fatty layer. So if someone tells you to name 9 layers of the anterior abdominal wall, then you add that one so that they become 9. But if someone asks you to name 8, then you can ignore that one. Then they become 8. So these are the layers of the anterolateral anterior abdominal wall in order from superficial to deep. Now let's flip the coin and ask ourselves, suppose we were going paramedian. The needle is being inserted paramedian, now not through the anterolateral side, but the paramedian side. What will the needle go through? So to address that question, let's look at it this way from this image. The first one is through here, the anterolateral region, and we've encountered those structures. So here we want to go through here. As you can see even from this image, instead of those 3 layers of muscles, we have just one muscle there. And so we are going to see what happens to these 3 so that we just have one as we go through the paramedian region. A magnified version of it will be better to use, and this is a magnified version of it. So instead of going through this part, anterolateral, we now want to go through here. Before I tell you the layers of the paramedian region, there's something you need to understand about the layer of muscles. The layer of muscles that we encountered in the anterolateral zone behave this way. There are flat muscles of the anterior abdominal wall. There are 3. As they approach the midline from where they come from, they form membranes of connective tissue. Membranes of connective tissue that come from muscles are called aponeurosis. So we have aponeurosis of the external oblique abdominis. We have aponeurosis of the internal oblique abdominis. And we have the aponeurosis of the transversal subdominis muscle. This is how the 3 aponeuroses behave. When these aponeuroses come towards the paramedian region, the 3 aponeuroses form a connective tissue sheath, which we call the rectus sheath. This rectus sheath contains a muscle within it, which we call the rectus abdominis muscle. Now, because it's a sheath containing a muscle inside, it means that that sheath will have an anterior layer and a posterior layer, or we talk of anterior lamina and posterior lamina. We can just use the term layers. So in cross-section, this is how the sheath would look like, with the muscle inside it. Now, how is this sheath formed? Now, follow with me. The aponeurosis of the external oblique abdominis continues to form part of the anterior layer of the rectus sheath. Similarly, the aponeurosis of the transversus abdominis continues posteriorly to form the posterior layer of the rectus sheath. However, the aponeurosis of the internal oblique abdominis splits into two lamina, the anterior lamina and the posterior lamina. The anterior lamina of the aponeurosis of internal oblique fuses with the aponeurosis of the external oblique to constitute the anterior layer of the rectus sheath. Similarly, the posterior lamina of the aponeurosis of internal oblique fuses with the aponeurosis of the transversus abdominis to constitute the posterior layer of the rectus sheath. Within that rectus sheath, we have a muscle that is running vertically or straight, and that's why it's called the rectus abdominis muscle. So with that understanding, we can now name the layers of the paramedian anterior abdominal wall. Again, let's assume that we are inserting a needle just off the midline. We still want to take out fluid. So the first layer that the needle go through is still skin, as we had indicated earlier. Then the needle go through the layer of fat, which I told you is called campus fascia. Then the needle go through the scarpus fascia, which is the membranous layer of the superficial fascia of the anterior abdominal wall. So those three are standard, irrespective of which part we are looking at actually. The difference comes from the layer of muscles. So instead of finding the three muscle layers, we now encounter first the anterior layer of the rectus sheath. And we've agreed that the anterior layer of the rectus sheath is formed by the aponeurosis of external oblique together with the anterior lamina of the aponeurosis of internal oblique. After that, then the needle will go through the rectus abdominis muscle. The rectus abdominis muscle arises from the lower parts of the sternum and the ribs and insert onto the pubic tubercle, or we can look at it the other way around. It arises from the pubic tubercle down there and inserts on the lower ribs and sternum. So it's a straight muscle. After the rectus abdominis muscle, then the needle will go through the posterior layer of the rectus sheath. And I hope you do remember that the posterior layer of the rectus sheath is formed by the aponeurosis of the transversus abdominis fused with the posterior lamina of the aponeurosis of internal oblique. After the posterior layer of the rectus sheath, then the needle will encounter the fascia transversalis and finally the parietal peritoneum. Again, remember that if someone is obese, then you may find variable amount of fat between the fascia transversalis and paratoperitoneum, what we call the extraperitoneal fat. So those are the layers of the paramedian anterior abdominal wall. Now let's flip the coin again and so look at the midline anterior abdominal wall and ask ourselves, what is then different if the needle was go through the midline of you? So in this case, we want to look at us traversing through here, the midline. Now not through paramedian or anterolateral, but midline. So again, before we go through that, there's some concepts you need to understand. So far, you've understood how the rectus sheath is going to be formed. Now, when the two layers of the rectus sheath approach the midline, this is how they behave. The anterior layer of the rectus sheath on one side crosses the midline and continues with the posterior layer of the rectus sheath of the other side. That means that there's crisscrossing at this point at the midline. So this posterior layer of the rectus sheath of this side crosses the midline and continues with the anterior layer of the rectus sheath of the other side. So what I'm saying is that the layers of the rectus sheath crisscross in the midline. That point of crisscrossing of the layers of the rectus sheath is otherwise known as the linea alba. And so if you are to be asked to name the structures that form the midline of the anterior abdominal wall, then we will still start with skin as we've done before. After that, we will talk about the fatty layer as we've done, then scarpa's layer as we've done. But then beyond there, we don't mention the muscle, we don't mention rectus sheath, we mention the linea alba. The linea alba is a fibrous tissue in the midline of the anterior abdominal wall. It's a relatively not so well vascularized region. And so if it's cut, it will not appear red, it will appear white. And that's why it's called linea alba, the white line. It's an important region surgically because it means that any cut through this point, there'll be less bleeding. And that's why emergency operations of the anterior abdominal wall would rather go through an incision in the midline through the linea alba because there's minimal bleeding and good exposure. Okay, the problem is that it will be also poor healing because of that blood supply, which is poor. Anyway, beyond linea alba, then we have fascia transversalis, and finally, we have the paratoperitoneum as well. So those are the layers of the midline anterior abdominal wall. And so I hope you've understood the three different zones of the anterior abdominal wall anatomy. That question can be asked in a different way. An incision is being made to remove the appendix. So which structures will the scalpel go through? So if you know the position of the appendix, then you know that it will be an anterolateral incision. All right. So that is the first agenda. We are done with it. Let's look at the second agenda. So our second agenda is to look at the inguinal canal anatomy. By definition, the inguinal canal is an oblique transmuscular passage in the lower parts of the anterolateral abdominal wall. I'm using the term transmuscular because it is going through, or it's traversing those three layers of the anterolateral anterior abdominal wall muscles. It is traversing those three flat muscles. Yet it's a passage for some structure. And it is on the lower parts of the anterolateral anterior abdominal wall. This passage is for the spermatic cord in males. The spermatic cord contains the vas deferens, contain the blood vessels which go to the testes. So remember, they come from the abdomen to the scrotum. So it passes through this inguinal canal. The spermatic cord passes through the inguinal canal. The female counterpart of such is not spermatic cord, but round ligament of the uterus. The round ligament of the uterus extends from the uterus to the labia majora in female. Again, it passes through the inguinal canal. But having said that, the inguinal canal is well developed in males than in females. The canal is more definite in males than in females. Apart from the spermatic cord and the round ligament, the inguinal canal also contains the ilioinguinal nerve in both gender. So this is the path. These are the structures within the cord. This is the cord itself. Why we learn the inguinal canal is because it's a potential site of weakness. It's a defect, which means that if you have raised intra-abdominal pressure, then there are chances that abdominal contents may go through that canal to come outside, and that's what we call inguinal hernia. Having mentioned that the inguinal canal is more developed in males than in females, we will expect inguinal hernias to be more common in males than in females. You'll rarely find a female with inguinal hernia, but you'll be coming across many men with inguinal hernias. One of the most common surgical referral, or let me say one of the most common surgical reasons why patients go to clinic. All right. In as much as we are saying it's more common in males, maybe not every man in this class has ever gotten an inguinal hernia. That means that there's some things that protect us from getting inguinal herniation. So at your own time, I want you to think through that again and ask yourself, what are the anti-hernia mechanisms? What are the mechanisms that protect against inguinal herniations? And look through the anatomical reasons that protect against inguinal herniations. So that even though we are saying, yes, men, we do have inguinal canal and it's a potential site for inguinal herniation, I'll not be surprised if none in this class has ever gotten an inguinal hernia, because there's some things that protect you against inguinal herniation. So at your time, just check on that. And when you do your practicals, we will revisit that story again. And we see what are the main mechanisms that protect you against inguinal herniations. But the image here shows you an example of inguinal herniation. The intestines can actually go through the inguinal canal. Usually the canal has two openings. The inner opening of the canal is called the internal ring, and the outer opening of the canal is called the external ring. So you have the internal ring and the external ring. Intersense can go through that, the internal ring, and pass through the canal, pass through the external ring, and even reach the scrotum, in which case we call it inguinal scrotal herniation. Very common in children. Okay, having talked about that, we can now look at the abdominal cavity and the contents of each region. Now, routinely, we can divide the abdominal regions into either 4 regions or into 9 regions. I want to teach you the latter, the 9 regions, because if you understand the 9 regions, then the former is very straightforward. Well, I'll still mention it, but I want to take more time on the 9 regions, because the 4 regions you can figure out easily if you've understood the 9 regions. Let's assume what I've drawn here is a person, so the waist region is somewhere there. This is assuming this is a woman, I think, from the shape. And let's take the dotted lines there to be the inguinal folds. So this is abdominal region, and this is the thigh, the left thigh and the right thigh. And these continuous lines represent the lower border of the ribs. We can use the term costal margin. So this is the right costal margin, and this is the left costal margin. The dotted line above represents the outline of the thoracic diaphragm. So at this point, it is important that you note that the thoracic diaphragm extends above the ribs. Okay, maybe not, that's not the right term to use. It extends above the costal margin. So it extends into the thorax to some extent. That's the point. The thoracic diaphragm is higher than the costal margin. In other words, I'm saying that the lower ribs cover the upper part of the abdomen. So the abdomen extends from there all the way to there. We divide the abdomen into 9 regions using 2 vertical lines and 2 horizontal lines. The 2 vertical lines are passing through the middle of the clavicle if you are to extend them upwards. And so we can correctly call them the mid-clavicular lines. This is the right mid-clavicular line, and this is the left mid-clavicular line. Remember, they're imaginary planes passing through the middle of the clavicle, but extended downwards, that's where they'll pass. We also have 2 horizontal planes. The one above is passing below the ribs, so we call it the subcostal plane. That one may vary. Some people may use the subcostal plane, and I find it easier to use that one because it's an easy landmark to pick. But some people use what we call the transpyloric plane. They're not quite the same, but they're near the same region. For the sake of consistency, you can use the subcostal plane. The one below passes above the iliac crests, just above the iliac crests. And so we call it the supracristal plane. Supracristal plane. Again, that one may also vary. Some people may use the line passing through the iliac tubercles. So they use the term transtubercular plane. still acceptable. I prefer using the supracristal plane because again, it's an easy landmark to pick. So if you take a line, an imaginary plane passing through the iliac crests of an individual, you call that supracristal plane. You take another line passing below the ribs of either side, then we call that the subcostal plane. Those are the horizontal lines. With the 2 horizontal lines and 2 vertical lines, we have now divided the abdomen into 9 regions. Remember the umbilicus, the navel is somewhere there in the middle. Now, what you're going to do next is very important. Very, very important. We want to give names to these 9 regions. And as we give names to these 9 regions, we're also going to name the abdominal organs which are housed in each of the regions. Let's start with the parts shaded green, which we call the hypochondrium. So this is the right hypochondrium, and this is the left hypochondrium. The plural of hypochondrium is hypochondria. They are named so because they are below the costal the costal cartilages. You know, chondro refers to cartilage. So let's start with the right hypochondrium. Which organs of the abdomen do we find in the right hypochondrium? Commonly, when I ask this question, which is a very straightforward question, people may still fail because you don't understand the question. Remember, we are talking about abdominal cavity. So the things you're going to name here are organs within the abdomen. Don't start talking about the lungs and the heart. I want abdominal organs. So I'll name for you 4 organs which are in this region. I'll start with the right lobe of the liver. It rests there. I'll also talk about the gallbladder. It rests there. Okay, you can call it gallbladder or gallbladder, whatever. Then I'll talk about the right adrenal gland. And I'll finish with the right colic flexure. The right colic flexure is the bend between the ascending column and the transverse column. Because that flexure is next to the liver, sometimes called the hepatic flexure of the colon. So I'll keep to those 4 in the right hypochondrium. And then go to the left hypochondrium. The organs which are found in the left hypochondrium include the following. I'll give you 5 here. I'll start with the fundus of the stomach. Then I'll talk about the spleen. Add to that list the tail of the pancreas. Then we can look at the mirror image from the right. So on the right, we had right adrenal gland. Now here we have left adrenal gland. Again, on the right, we had the right colic flexure. So on the left, we have the left colic flexure. That left colic flexure is next to the spleen, so it is otherwise known as the splenic flexure of the colon. So remember those 5 organs on the left hypochondrium. Now we come to this region. This region is known as the epigastrium because it's above the stomach. So which organs do we have in the epigastrium? The epigastrium contains the left lobe of the liver. Apart from the left lobe of the liver, We also have the body and pylorus of the stomach in this region. So the body and pylorus of the stomach. We also have the head and body of the pancreas in this region. And you can add to that list the duodenum. So further posterior, we will have the descending aorta. Further posterior is the aorta. Aorta also passes, but it's much posterior, much behind, but still there. So the left lobe of the liver, body and pylorus of the stomach, body and head of pancreas, duodenum, and the descending aorta. Then we go to these other regions, which we commonly call the flank. I prefer if you call them the lumbar regions. We have the right lumbar and the left lumbar. This is the right lumbar, and this is the left lumbar. So what do we have in the right lumbar? We can mention three important ones here. Remember, the right kidney is there. Remember, we have the ascending colon here. And we have the right ureter. Of course, the right ureter is arising from the right kidney. I want to limit it to those three so that we keep it simple. Right kidney, right ureter, and the ascending colon. Okay. I'm giving you now 2 seconds to think through what is found in the left lumbar region. And if we have a volunteer, you can just unmute and volunteer to tell us. If you put up your hand, I'll enable your mic. Anyone who wants to volunteer, what could be found in the left lumbar region? Yes, I'll give it to Sumaya. Carry on.
The left kidney.
Very good. Anything else?
Left ureter.
Very good. And lastly?
Only that.
Okay, no problem. Thank you. So left kidney, left ureter, that's good. Who wants to give us the last one? Yes, Vivian.
The descending colon.
Very good. Thank you, Vivian. So we will work with those three again on that region. Left kidney, left ureter, and the descending colon are contents of the left lumbar region. Then we come to this yellow region, which is the central part of the abdomen, and that's what we call the umbilical region. So the umbilical region houses a number of things. It has the coils of the small intestines. And in this case, we are talking about ileum and jejunum, or let me say jejunum and ileum. So we have the coils of the jejunum. We also have the coils of the ileum. Apart from those are parts of the small intestines. Apart from those, we also have the transverse column. Now, you see the transverse column comes this way. We have the ascending column here, then the right colic flexure, then the transverse column is redundant, so it comes like that. Then the left colic flexure, then the descending column. So the transverse column is redundant around this region. Then we can add, still in this region, the aorta as well as the inferior vena cava. So add aorta and inferior vena cava there. Those are the contents of the umbilical region. Down to those red regions, we call them the right and the left iliac fossa. Okay, some people call them the right and left inguinal regions. I prefer the term iliac fossa. So the right iliac fossa contains the cecum. It also contains the appendix. Apart from those parts of the GIT, the right iliac fossa will also have the right ureter. You know, right ureter will traverse there, then go through there before it reaches the bladder. So the right ureter. And in females, we will add the right ovary. Of course, you know that in males, we will not add the right testis there. But in females, we have the right ovary. So let's skip to those four on that region. Then on this region, we will still have the left ureter and the left ovary in females. The part of the the part of the digestive system, which is in this left iliac fossa, is the sigmoid colon. So don't talk of right appendix and right cecum. We don't have those ones. We talk of the sigmoid colon in this region. Then finally, this is a region we are finishing with, the blue region. I hope that is blue. And I've just discovered this is also blue. Anyway, so this one here is known as the hypogastrium. The hypogastrium is also known as the suprapubic region. So what do you have in the hypogastrium? When the urinary bladder is full, it extends here into the hypogastrium. So that means we can mention a full urinary bladder. Please note that when the bladder is not full, it is not a content of the suprapubic region. It is not a content of the abdomen. It is a content of the pelvic cavity. So urinary bladder just extends to the abdomen when it is full. Otherwise, it is not found in the abdomen, it's found in the pelvis. So one of the organs is the full urinary bladder. The other one is a gravid uterus. Gravidity refers to pregnancy. So gravid uterus is a uterus with a child inside. If the uterus has a baby, then it will extend to the abdomen. You'll be told that the uterus usually reaches the abdomen when the woman is 12 weeks pregnant. From 12 weeks onwards, the uterus is an abdominal organ. Before 12 weeks, the uterus is a pelvic organ. So again, it means that you can only have the uterus here if it has something inside. From a physiological point of view, pregnancy. Well, pathological could be there's a tumor or fibroid, whatever. But let's forget pathology for now. So some normal physiology, uterus will extend to the abdomen if it is gravid. Otherwise, it is not an abdominal content. So in the absence of pregnancy and a full urinary bladder, what do we have here? That's a big question. And usually here we will have the coils of the ileum. The coils of the ileum are the ones that extend here in the absence of pregnancy, as well as absence of a full urinary bladder. Also here you may have the coils of the sigmoid colon. So coils of ileum and coils of the sigmoid colon. Remember, it's not jejunum at this point, it's just ileum. Coils of the ileum and coils of the sigmoid colon. Then you can add full urinary bladder and gravid uterus. Please don't put here rectum, vagina. You know, those are not contents of the abdomen. If you know that anatomy well, those are contents of the pelvis. So that summarizes the story of the 9 abdominal regions and the contents of each. So I want you to revisit that story again and just familiarize with those 9 regions of the abdomen. and the organs which are found in each region. Familiarize with them. Patients will come to you and you'll be expected to figure out, so which organ is swollen, which organ is bringing the trouble, based on the symptomatology that the patient will come with. I'm feeling pain in this region, and they'll show you where the pain is maximal. And then maybe you palpate, you'll feel something swollen. The term we use in medicine is organomegaly. You'll feel organomegaly. So which organ? Your anatomy, your knowledge of the anatomy of the organs of the abdomen will tell you, will help you to know which organ is swollen in which region. So those are the 9 regions. Now let's go through the 4 regions. We divide the abdominal cavity into 4 quadrants using 1 vertical line and 1 horizontal line. Those lines pass through the umbilicus, so we can just call them transumbilical lines. We have the vertical transumbilical line, and we have the horizontal transumbilical line. With that understanding, we have divided the abdomen into 4 quadrants, and their names are very simple. Right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. Now, the organs found in each of these ones will be somewhat reflecting what we've already talked about. And so I really don't want us to go through that repetition again. But at your own time, then reflect on that and ask yourself, so what do I put on the right upper quadrant? You'll find that you'll now put the liver there. You may not want to then divide it into right and left lobe because most of it will be here anyway at this point. But things like kidney, you will realize that you'll have to now cut them into 2. So you talk of upper pole of the kidney, then lower pole of the kidney in the right lower quadrant, something like that. There are some organs that you may have to split somehow. So at your own time, again, I'm giving you that to just work on it. So ask yourself which organs are found in the right upper quadrant, which ones are found in the left upper quadrant, left lower quadrant, and right lower quadrant. If you've understood the 9 with the contents of each, then you can understand the 4. That diagram will help you to figure out a number of those things. You can get this in any book, so don't worry, you don't even have to be copying this one in a hurry. All right, that then brings me to the last part of the lecture, which is talk about the thoracic diaphragm and the structures which go through it. Before we do that, I'm giving you a question. The intention of this question is so that I can collect attendance of the class. So make sure you respond, and you have 1 minute to this. You just respond by writing, is it A, is it B, is it C, D, E, or F? So I'm the only one who can see your responses. You write in the chat. You can start, you have 1 minute. Okay, I'm closing it. Your 1 minute is over. I am a bit surprised by the responses though, but the main aim was to collect the attendance. Now, the thoracic diaphragm is a dome-shaped muscle that separates the thorax from the abdomen. This muscle is a thin muscle and is separating the abdominal cavity from the thoracic cavity. It is a primary muscle of respiration innervated by the phrenic nerve. The muscle has 3 parts. There are those parts of the diaphragm which are attached to the lumbar spine. The parts of the diaphragm that are attached to the lumbar spine are known as the crus of the diaphragm. So you have the right and the left crus of the diaphragm. Then you have the parts of the diaphragm that are attached to the ribs. We call them the costal parts of the diaphragm. The costal part of the diaphragm. Then the musculature of the diaphragm, whether from the costal parts or from the lumbar region, they insert into a central aponeurotic region. The central aponeurotic region of the diaphragm is known as the central tendon of the diaphragm. So this is the central tendon of the diaphragm. It's a central aponeurotic region which forms the insertion of the different musculature of the diaphragm. Going through the diaphragm are some structures. And those structures will then go through openings. There are 3 well-defined openings of the diaphragm. Let's start with the opening that is high up, which we call the caval opening. The caval opening is located at around the level of the 8th thoracic vertebra. It's the highest opening of the diaphragm, the level of T8. So the caval opening, as the name suggests, is the opening of the inferior vena cava. Remember, inferior vena cava carries blood from the lower part of the body. So it definitely must go through the diaphragm for it to reach the heart. Apart from the inferior vena cava, the caval opening also traverses the right phrenic nerve. The right phrenic nerve goes through the diaphragm so that it can supply the biliary structures. The second opening is known as the esophageal opening. The esophageal opening is at the level of T10. So the plane of the 10th thoracic vertebra is the opening of the esophageal opening of the diaphragm. As the name suggests, that is where the esophagus goes through. So again, you know that esophagus, the food pipe, it must go through the diaphragm. From the upper part, it must go through the diaphragm to reach the stomach. Apart from the esophagus, there are 2 other things that go through the esophageal opening. We have the vagus nerves. Remember, the vagus nerves are the 10th cranial nerves. So usually by this point, we don't talk of right and left vagus nerve. We talk of anterior and posterior vagal trunk. The left vagus nerve is the anterior vagal trunk, and the right vagus nerve is the posterior vagal trunk. The reason as to why they're called anterior and posterior vagal trunks is largely embryological, based on the fact that the stomach rotates, so that the left part of the stomach becomes anterior and the right part of the stomach becomes posterior. We will talk about that when you look at development and congenital malformations of the digestive system. But having said that, we talk of vagal trunks instead of the right and left vagus nerve. So the vagal trunks go through the esophageal opening. The third entity that go through the esophageal opening is the left gastric vessels. The left gastric vessels are vessels that supply the stomach and the lower part of the esophagus. So the ones that supply the lower part of the esophagus will go through the esophageal opening so that they can supply the lower part of the esophagus. Left gastric vessels. The last opening is the aortic opening, which is located at the level of the 12th thoracic vertebra. As the name suggests, it is the opening of the aorta. So this is the region, this is the part that aorta uses to pass through from the thoracic region to the abdominal region. So the thoracic aorta becomes the abdominal aorta through this point. The aortic opening traverses the descending aorta. Apart from that, it also traverses the thoracic duct. The thoracic duct contains lymph from the lower part of the body. So the lymph from the lower part of the body passes through the thoracic duct to go to the upper part of the body. It's the largest lymphatic channel in the body, thoracic duct. Apart from that, we also have the Azygos vena system. The Azygos vena system are the veins which drain the posterior abdominal wall as well as the posterior chest wall. So the veins begin from below, they go through the aortic opening, then now continue to become bigger in the thorax, the Azygos vena system. Well, so those are the structures which go through the diaphragm at different openings. So when I asked you this question, some people didn't even see the trachea there, because trachea was the correct response. I mean, why should the trachea go to the abdomen? To breathe what now? Okay, so that is the anatomy of the diaphragm, and that summarizes what we were meant to learn today. We've gone through the layers of the anterior abdominal wall in the three entities: paramedian, midline, and anterolateral. We've also looked at inguinal canal. I've given you an assignment there to look at the anti-hernia mechanisms from an anatomical point of view. We've gone through the regions and contents of each region of the abdominal cavity, and I've given an assignment there again to look at what is found in each of the 4 quadrants of the abdomen. So I'll stop there and give you a chance to ask questions. Our next topic, which we'll be doing next week, we'll be starting anatomy of the digestive system.